Good morning, everyone. Let me welcome you all for another webinar of the webinar series organized by Society, Health, Research and Innovation. Today, the webinar is on initial approach to trauma management in emergency department. Before the commencement of the webinar, let me give some housekeeping messages. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late attendees will be entertained thereafter. And each attendee should have been attended till the end of the webinar to obtain the certificate of CPD points. And these CPD points are strictly adhering to this national CPD guidelines. We all are strictly adhering to these guidelines in order to maintain the standards of this CPD program. So we thank you all for your strict adherence to these CPD regulations and also your kind compliance to the webinar series every Sunday, updating your knowledge. So without further ado, let me introduce you our distinguished speaker today. He is Dr. Bandara Ekanayake, consultant emergency physician in National Hospital of Sri Lanka. His topic today is initial approach to trauma management in emergency department. Over to you, sir.
Good morning, everyone. Thank you, Ganga, for your kind words of interaction. And first of all, I must thank Sri for organizing this kind of educational intervention, basically for the doctors who are dealing with the patient care. Okay, let's move on to our topic. Today, I'm going to talk about the initial approach to trauma, basically trauma management in emergency department. Okay. Why we need to consider trauma in the emergency department? Basically, the trauma is the main cause of death, especially in the productive age, especially the economic productive age. If you consider road traffic accident, it kills 6 or 7 people per day. This is Sri Lankan data. And out of that, 2/3 basically in the economic productive age, that is 15 to 64 years of age. When you consider the road traffic accident, it usually kills motorcyclists mainly, and the pedestrian and the drivers, mainly the three-wheeler drivers. That is why we need to consider this trauma management very important. That's why I am going to talk about this trauma initial approach, especially in the emergency department. When you consider the trauma, especially, we're going to follow a certain protocol. Usually, we follow advanced trauma life support protocol or approach. In there, what you usually describe in is the primary survey we're going to do first. In primary survey, we are going to assess several components. And once you identify these components or injury or life-threatening injuries, you need to do a resuscitation immediately. Even though it is bulleted 2, you need to consider, you need to manage patient simultaneously. That is primary survey amalgamated with resuscitation. Then you can go ahead with the secondary survey and definitive therapy, and as well as the post appropriate care. When you consider primary survey, what our main objective or goal is to identify life-threatening injuries. We need to identify the life-threatening injuries and treat them and there. That is the main aim of doing primary survey. Before you enter into a primary survey, you need to see whether scene is safety. You might wonder why I'm saying this scene is safe. You need to consider this scene is safe. If you're a pre-hospital care person, then definitely you need to think about patient might be in the road and you are unsafe to enter, or if patient is in the building, maybe unsafe you to enter or approach. But in the hospital setting, what do you mean by scene safety? For example, if patient who is coming following the step, the culprit person who is also accompanied and making the scene unsafe for you. Therefore, please make sure you are safe in the scene as well as you are safe yourself. Then after, you can enter or you can approach in the primary survey. This is my main slide, which I'm going to talk today, is the ABCD approach. This is the primary survey, or this is the ATL approach for basic or trauma management. In airway, in A, you consider airway as well as the cervical spine. And B, you usually talk about the breathing and the ventilation. And the C, circulation, and the especially hemorrhage control. And the D, disability, usually you assess the conscious level and the patient's the neurological status. And the exposure, what you usually considering is the temperature, and you need to expose patient and see if there anything danger. This A, airway and cervical spine control, why it is come first is usually the people who have trauma, the majority die because of airway problem. That is why it's come first. But if patient is having a catastrophic bleeding, usually like a amputated limb, amputated extremity, or significant degloving injury, or significant laceration, then you need to do immediate management for that catastrophic bleeding. Therefore, if there is a catastrophic bleeding, C come first, and then you need to follow A and B. Okay. For example, you can see this amputated limb. Probably he might die. All blood might be escaped from his body, and he might die because of this catastrophic bleeding. Unless we control that, this catastrophic bleeding, patient might die. Therefore, appropriate the measures, for example, applying the pressure, immediate applying application of pressure, or sometimes tourniquet is mandatory to control the catastrophic bleed. We'll go to the A first, airway. What are the main objective you to assess or you to consider when you look in A or airway? Patient who is coming with trauma might have an airway problem or airway obstruction. How do you identify patient whether patient is having an airway obstruction? For example, if I am a patient who is coming with trauma, somebody say, okay, I'll speak to the patient and assess whether he is having a patent airway or not. For example, as I mentioned, I'm a patient who is coming following a trauma, and somebody is asking, okay, what is your name? Then I say Bandara. Then sometimes they might think, okay, my airway is patent. Suppose if another person asking me, what is your name? And then I'm saying, my name is Bandara. Then it is two different. First, I mention only one word. Then secondly, I mention three words. That is a sentence, which I can say like this. For example, if I am having an injury and then I am saying, my name is Banna, then it is also quite different. I can't complete sentence in a single breath. If I can say, I can confidently say your airway is patent. But if I have interrupted or incomplete interrupted sentence, then patient might have airway threat. Please make sure you ask patient a full sentence and to give a full sentence word or full sentence answer to assess whether the patient is having a patent airway or not. Please not a single word. A single word does not say anything. But if patient can complete a sentence uninterrupted sentence in a single breath, that does imply patient is having an airway patency, but make sure this is for that particular instance only. Next instance, patient might go into a complete airway obstruction. For example, if patient who is coming with burns or airway burns or facial burns, patient might go into an imminent or immediate airway obstruction if you are not intervened properly or if you are not assess patient in a regular basis. Therefore, when you identify a airway threat or airway problem, you need to say, this patient is having airway patency at this particular moment. And you need to, if you suspect, if a gustatory is if you're thinking that this patient might have a problem, then you need to repeatedly assess this patient. In addition to airway main obstruction because of foreign body, there might be a penetrating or other injuries usually causing like hematomas around the neck also can cause airway disruption or airway obstruction. Therefore, please make sure that you are getting a patient whether the patient is having an airway patency or not. Why this airway patency is so important? Patient who is having a patent airway and a partially obstructed airway have a significant impact on the flow, basically the oxygen flow or airflow. Therefore, please make sure that whether the patient is having an airway obstruction or not. If patient is having the airway obstruction, you have a simple maneuver that is jaw thrusting. Currently, there's a limited chin lift also recommended, but I am usually saying jaw thrust is better all of three. That is head tilt, chin lift, and jaw thrust. But we are not recommending head tilt at the trauma, but limited chin lift and jaw thrust is usually recommended. The patient is having a secretion, you need to suck out. And if you have oropharyngeal airway and patient is having a blunt airway response, you can insert or nasopharyngeal airway. But make sure patient who is having a head base, basically base of skull fractures, you are not going to insert a nasopharyngeal airway because it might end up in the brain. This is a simple maneuver how you do the jaw thrusting, but I'm sure definitely you all know about how to do a jaw thrusting. These are basic airway adjuncts, oropharyngeal airways, and on the right-hand side, you see some nasopharyngeal airways and other airway devices you can use to protect patient's airway or to make the patent airway make the patient's airway patent. As I mentioned, there are some signs you can elicit if patient is having an airway obstruction. These are snoring, gurgling, stridor, silent chest. I will talk about in detail in the breathing part. Okay. Then we consider a cervical spine immobilization. Suppose a patient who is coming with trauma, you have two patients. Suppose there are two people who is traveling in a three-wheeler and then met accident. And both are in same age group. Suppose both are in, you have an X and Y patient, and X is 25 years and Y also 25 years, both are males, and coming into your emergency department. One patient who is conscious, who is rational, and GCS of 15. Other patient Y, who is having a GCS of 13 and is a bit confused. Do you think which patient is having a cervical spine injury? Okay, if your answer is both, I'm so happy because by saying whether the patient is conscious or not might not have a good impact on cervical spinal injury assessment. But if you consider a patient who is having a reduced level of consciousness, definitely it has a 3 times higher risk of cervical spinal injury than patient who is completely conscious, who is having a GCS of 15. Make sure the people who are coming with trauma having a reduced GCS have a higher incidence of cervical spine injury. Therefore, please make sure that who are coming with trauma have to have a cervical spinal protection or immobilization. How do you do the cervical spine immobilization? Okay, already we have talked about the airway, and in A, you need to consider this cervical spinal immobilization. How do you do cervical spine immobilization is, first thing is, how do you do is the basic manual inline stabilization. You go behind the patient, as in the left-hand side slide, you need to do a cervical spine immobilization. Manual inline stabilization. What do you mean by this inline? You know that it is manual, definitely. But what do you mean by inline stabilization? Inline, it means there are few points should be in same line. Those are tip of nose, the manubriosternal junction, and the symphysis pubis, and the two great toes. If those all fall in one line, that does imply inline stabilization. Okay, please make sure that sometimes I might see a patient who is having a cervical spine immobilized, but patient, the rest of the body, it's not in line. Patient who is coming with trauma, basically the significant trauma, you need to see whether the patient is in line. Please make sure that patient is in line in addition to cervical spine immobilization. First thing, as I mentioned, you go ahead with the manual inline stabilization. Then you can aid with the hard cervical collar. Usually we prefer Philadelphia collar, but there are other commercially available like Miami collar and the Aspen. These are available. Then you can use these collars. And in addition, you need to keep the patient in a trauma mode. Why I'm saying patient should be in a, as a log, you need to take a patient and then you need to keep the patient in a trauma mode. Okay. When you apply, when you are going to keep the patient on the trauma board, then there are sometimes you might have head blocks and the straps you need to put in. The one thing is over the forehead and other in the over the chin. These are the basic method you to consider cervical spine immobilization. What are those? First thing is manual inline stabilization. Make sure all four lines, as I mentioned before, should be in line. Second, you need to take the cervical collars, which are either which are Philadelphia collar, either Miami collar, or Aspen. These are hard cervical collars you to apply. In addition, third thing is patient should be on a trauma board. And if patient is on a trauma board, you can apply this head blocks and strap one over the forehead and other over the chin. This is good for a patient who does not have cervical spine, like previous cervical spine problem. For example, suppose Archie is coming with cervical, so you are suspecting cervical spine injury, and she might have scoliosis or kyphosis, and patient is having a little bit forward bending of neck. Then you need to do a cervical spine protection, and you're going to apply this hard cervical collar. What you do in this hard cervical collar is to make your spine straight. And if you're going to forcefully going to apply this to that Archie, then she might end up with the cervical collar-induced fractures. For that, usually I prefer if patient who is coming with trauma, ideally on the trauma board, and to apply the hard blocks on the patient's either side of the face and to strap. But if patient is having a little bit of bending forward, then you can padded it under her head. You can padded it some cloth or some materials. Then it will be so comfortable for that patient. Please make sure you're going to apply a proper care for an appropriate patient. Not all patients need hard cervical collar, but patient who is coming in definitely need to have a cervical spine immobilization. But make sure either patient is on the hard cervical collar, usually young patient who is coming with injuries, you can apply hard cervical collars. and then put into the trauma ward. But patient who is like that RT, who is coming with trauma, might have a problem with cervical spine pre-existing. Then patient should usually put on the trauma board, and on the trauma board, you put the two head blocks on the either side, and then padded some cloth or some materials underneath her head, and then a strap. That is ideal for her to have a cervical spine immobilization, like that. Okay, fine. How do you identify whether the patient is having a cervical spine injury? There are criteria. This is a simplest criteria, is the nexus, which you can apply patient who is coming with trauma. There are 5 things. One thing, whether the patient is having an altered level of consciousness. Second, whether the patient is intoxicated. Third one, whether the patient is having a focal neurological deficit. Fourth one, whether the patient is having a painful, distracting injuries. Fifth one, you need to identify whether the patient is having a posterior midline cervical spine tenderness. If those 5 is not there, then you can say this patient does not have a cervical spinal injury. But make sure before that you ask patient to do 45-degree left and right up and down movement and see whether there is any tenderness over the cervical spine. If it is not, then it is clinically cleared. Okay. This is how you're going to assess cervical spine in a patient who is coming with trauma. But suppose patient who is coming with blunt or patient who is altered level of consciousness, you can't assess the rest of the thing. Then you apply a cervical collar and you proceed with the next step, that is breathing. In breathing, what are going to usually identify whether the patient is having any problem in chest. But I included these 5 in the breathing part, which are, you're going to identify whether the patient is having a tension pneumothorax, massive hemothorax, open pneumothorax, flail chest, and ruptured diaphragm. But when you consider in chest, that pericardial or passive pericardial effusion also, or the cardiac tamponade also come into play in the chest. How do you identify whether the patient is having a respiratory distress? Is the main problem here. You're going to assess the breathing part, and in breathing part, what you're going to assess whether the patient is having a respiratory distress clinically. There are some sets of some signs and symptoms are there you to identify whether the patient is having a respiratory distress. There are some noises which are called respiratory noises. The God has given us some respiratory noises you to identify where the patient is having the distress. For example, if you hear a sound of gurgling, you know that definitely patient is having an oropharyngeal area, some secretion. And if patient is having a stridor, you know that the patient is having upper airway obstruction, imminent, basically the partial upper airway, critical partial upper airway obstruction. Do you know how to identify? I know definitely you all know how the patient comes with stridor sensor. And other symptoms are like spasm in the small airway, which denotes as a bronchi or wheezing sound. And if patient is having some secretion or some alveolar exudate, you can hear a crepitation. Therefore, please make sure you treat these accordingly. Not all patient who is coming with respiratory noises need nebulization. Okay? The patient who is coming with secretion, that is gurgling sound, you need to suck out the secretion. The patient who is coming with upper airway obstruction, which denoted as a stridor, you need to identify where is the obstruction, and if you can take it out and under direct vision, then you need to take it out. Otherwise, you need to make the patient airway patent by some. Okay, there are methods you to apply. I'm not going to talk about that in detail, but definitely you need to clear up the airway. And if patient who is having a problem in the small airway, which is denoted as a bronchi or wheezing sound, you can apply some nebulization. Okay. According to these symptoms, according to these signs, you need to give your management appropriately. And there are signs of inadequate oxygenation, which are patient might be restless and drowsy, patient might have a cyanosis, it's delirium, and maybe tachycardic tachypnea. In respiratory system or in breathing, what you're going to mainly assess, one thing is whether the patient is having a respiratory distress and inadequate oxygenation signs, which are accompanied by assessing the respiratory rate as well as the saturation. If patient is having a respiratory distress, you need to apply oxygen. Anyway, patient who is coming with significant trauma, I prefer patient on oxygen. Why? Because patient is having a significant basal increase in basal metabolic rate. Therefore, patient's demand, oxygen demand is so high. Even though patient is maintained in saturation 94, please make sure give additional oxygen, which might need patient a bit later. Okay? This oxygen, application of oxygen or administration of oxygen is so important because you can identify whether you are doing correct thing. For example, patient who is coming with significant trauma, who is having a saturation of 90, what are you going to apply? You're going to apply a nasal pronounced oxygen, whether you're going to apply a face mask oxygen, whether you're going to apply a non-rebreathing face mask. This is totally depend on the patient's condition. What my main target is to achieve saturation of 94 to 90. That is my main target. To achieve that target, there are different interfaces you will need to use, which are, there are some different interfaces you need to use. These are, there are some interface, the nasal prawns, face mask, that is called Hudson face mask, non-rebreathing face mask. In addition, there are some other oxygen delivering devices are there, like high flow oxygen or non-invasive ventilation. In this slide, you can see that there are sets of oxygen delivery devices, which I usually call interfaces. Nasal cannula is the first. Okay, suppose you are getting a patient who is having a saturation, oxygen saturation with trauma and saturation of 92. Which interface you prefer? Does it nasal cannula or simple face mask or a Hudson mask or non-rebreathing face mask? I'm talking about these three because these three are commonly available in our settings. Patient who is coming with saturation 92, I'm really worried because he is in that oxygen dissociation curve. You can remember your the physiology. At this 92 is at the shoulder tip. Patient can drastically drop saturation or the oxygen level of the oxemia in the blood significantly if you drop further. Therefore, you need to apply a good amount of oxygen. I prefer either simple face mask or non-rebreathing face mask. Non-rebreathing face mask is so important because you're going to apply a significant amount of oxygen to the patient. When you consider non-rebreathing face mask, it is how much you're going to apply is you're going to apply 10 to 15 liter of oxygen. 10 to 15 liter of oxygen you're going to apply through non-rebreathing face mask. Suppose you're going to apply a patient who is coming with trauma and patient is maintaining saturation around 92, 93, 93. Okay. Then you can apply oxygen through simple face mask, that is Hudson face mask. But I'm not saying, but make sure you're not going to apply oxygen to a patient who is coming with trauma through nasal probes, because you ideally know that the patient, if you can see this slide, patient who is coming, if you are going to apply nasal cannula oxygen, you can apply flow rate of 1 to 6. But maximum saturation or the concentration of FiO2 you can get is 44. But patient who is coming with significant level of desaturation, either you need to give oxygen through the simple face mask or non-rebreathing face mask, but I prefer non-rebreathing face mask for a patient who is coming with significant trauma. When you're going to apply any interface, there are sets flow rate. For example, if you're going to apply a nasal cannula by some instance, you can apply you can apply a flow rate of 1 to 4. Even though it mentioned in here 1 to 6, patient who is going more than 4, it is so discomfort patient to have a flow rate of more than 4. Therefore, if you're going to apply a flow rate of 1 to 4, apply a nasal cannula. And if you're going to apply a simple face mask or a Hudson face mask, you need to give at least 5 liters per minute. I'm seeing some people are getting oxygen through this face mask of 2 liters. It is so irrational, because if you're going to apply a flow rate less than this, less than the indicated value, then it is patient is going to breathe their own carbon dioxide. Okay. Therefore, please make sure you're going to apply your appropriate flow rate. I'm repeating that one. If you're going to apply a nasal cannula, you can give a rate of 1 to 4. And if you're going to apply a simple face mask, it is 5 to 10 liters per minute. Not less than that, or not more than 10, because no point of giving more than 10 liters per minute through face mask. If you're going to give more than 10, definitely you need an non-rebreathing face mask, which usual flow rate is 10 to 50. Okay. Therefore, please make sure you're going to apply appropriate oxygen delivery devices or appropriate interface, and then you identify how much flow rate you're going to apply and what is your target. Okay, please make sure that all the patient who is coming with trauma, whether they are carbon dioxide retainer or not, your target should be 94 or 94 to 90. There's nothing called carbon dioxide retainer. Okay, it's a myth, but I'm not going to talk about in detail about that carbon dioxide retaining. But in the acute patient who is coming with trauma, need to have maintained saturation 94 to 98. Okay. Therefore, you need to maintain that flow rate, appropriate flow rate to maintain appropriate saturation or your target saturation. In addition to applying oxygen, you might need to insert intercostal tube. And for example, if patient is having a tension pneumothorax, which we usually prefer is wide bore cannula or the needle thoracentesis, and followed by intercostal tube. But as emergency people, what you usually prefer is you put finger thoracostomy and immediate insertion of IC tube. Okay, because needle thoracentesis, it takes so significant time to escape that. Yeah, but if you're going to do a finger thoracostomy and insertion of intercostal tube, you can release that tension so suddenly. Okay, please make sure to adhere that. Then we move into a circulation. As I mentioned, if you identify it is a catastrophic bleeding, then you need to do immediate management, like application of pressure immediately, or bandage, or application of that. But if it is not, then you can go ahead with the circulation as no routine. In circulation, what you are usually identifying is whether the patient is having any hemorrhagic shock. To identify whether patient is having a hemorrhagic shock, you have different sets of signs and symptoms. What are those symptoms? Patient is complaining of thirsty, and patient is sweating a lot, and patient is asking for water. And these are very significant signs of patient who is coming with trauma, who is having a hemorrhagic shock. In addition, patient is showing a sign that the patient is pain, is having a cold extremities, clammy peripheries, and heart rate is high and blood pressure is low. You know how to identify patient who is having a trauma, who is having a hemorrhagic shock. There are grades 1 to 4. Okay, depending on the patient's blood pressure, clinical symptoms, heart rate, you need to identify whether the patient is in hemorrhagic shock or not. In addition to identification of this, there is a theory of calculating the shock index. Please make sure to put the patient shock index in your BHT. How do you calculate the shock index? Is heart rate divided by systolic blood pressure. Shock index is so important that once patient admitted to your emergency department who is having a shock index of more than 1 have a significant risk of death or high risk of mortality, as well as long hospital stay and disability. Therefore, make sure you calculate shock index, and it's also important you to guide fluid therapy, blood therapy as well. In addition to assessing this one, you need to manage the patient's hemorrhagic shock. How do you manage? You insert 2 wide bore cannulae. Usually I prefer at least 16 gauge of cannula in the antecubital fossa, or whichever you can apply, or wherever you can insert this cannula, but it should be more proximal to the body torso. Okay. If you don't have, if you fail to insert intravenous cannula, please make sure at least you get an intraosseous access. Okay, this is how you're going to apply a pressure over a patient who is coming with trauma. For example, if I'm having an injury or significant laceration which causing significant bleeding over my hand, then what I can do is, what you can do as a healthcare personnel is to directly apply pressure. You put a glove and then directly apply the pressure. And then you can apply a bandage. And for example, if you have a significant bleeding, which patient is going to death or going to have an imminent death, you can apply a tourniquet. Okay. In addition, since you are in the hospital setting, you might identify bleeding culprit vessel, and then you can ligate it through the arterial clamp or simple ligation. Okay, this is how you define the classes of shock. You know by your final MBBS knowledge, there are 4 classes of shock: mild, moderate, and severe, and the class 1 in addition. If you have a bleeding more than 40%, you are in the class 4 shock. In there, you have significant in class 4 and class 3 shock are very important in our emergency department because we are dealing with bad people. In there, usually patient is having a significant low blood pressure and pulse pressure is low, and patient in addition, patient is having a significant high heart rate. Okay, if you happen to do a blood gas, it is very rational to do a blood gas for a patient who is having a trauma because you can identify base deficit and to guide where the patient is in, which class of shock patient is in. Okay, if patient is definitely in class 4 shock, you need to activate the massive transfusion protocol. Okay. Okay, now we have already completed airway assessment and cervical spine and breathing. And then now you are in circulation. Suppose patient who is having a significant bleeding and you need to transfuse blood. But to buy time, you're going to infuse 0.9 saline, that is so-called normal saline, or you can use Hartmann. But make sure it is not going more than 1 liter per adult or 20 ml per kg in child. Usually we are going to give 10 ml per kg for every people, including children, but should not go beyond 1 liter for adult or 20 ml per kg for a pediatric patient. While you are infusing crystalloid, you need to get down blood. What are the blood components you need to get down? Firstly, you can ask for an uncross-matched blood, that is O negative. Sometimes you can infuse O positive blood as well if you don't have O negative blood. Then you can ask for a group-specific blood. Then you can ask for a cross-matched blood. But if you're going to activate massive transfusion protocol immediately, then you get blood in a different compound or different set of packs. Okay. Okay. Now you have a patient who is having a hemorrhage, and then you give intravenous fluid. Then that is basically for buy time, and then you get blood and you infuse blood, either massive transfusion or a simple transfusion protocol. In addition, you need to control it biochemically. What are the chemical agents to control bleeding, which are tranexamic acid? In addition, if patient is on anticoagulant, for example, if patient who is on warfarin, you can give PCC. Okay, okay, the compound concentrate, platelet compound concentrate, or factor concentrate, you can infuse. Okay, or if patient is on anticoagulant like warfarin, we can give vitamin K as well. What are the main what are the main hemorrhagic, the main agent you are going to give if patient who is in hemorrhagic shock? You give tranexamic acid. Okay, tranexamic acid. How much of tranexamic acid usually you're going to give? Tranexamic acid first you're going to give 1 gram over 10 minutes, and then 1 gram over 8 hours as an infusion. That is usually 60 ml per hour infusion. What is the time level you're going to give tranexamic acid? It's usually within 3 hours of injury. Okay, not 3 hours of hospital admission, 3 hours of injury. Okay, these are how you're going to manage a patient who is having a hemorrhagic shock. I'm going to mention about a little word about the massive transfusion protocol because it's so important. There are several criteria you to activate massive transfusion protocol. First of all, we see what is massive transfusion. It is transfusion more than whole blood within 24 hours. Or if you consider a major hemorrhage, if you're going to lose your whole blood within 24 hours, it is called massive hemorrhage. And if you're going to lose your 50% of total volume within 3 hours, that is also called significant or major hemorrhage. Or else, more than 150 ml per minute, it's also called major hemorrhage. If patient does have these signs or symptoms which causing this kind of a bleeding, patient definitely should be in the massive transfusion protocol. That is the ideal. How do you identify? There are set scores. We usually follow this ABC score. If you have a 2 scores out of 4, then you can activate massive transfusion protocol depending on the clinical situation. Okay. What are those? Penetrating mechanism. If patient is having a systolic blood pressure of less than 90, heart rate of more than 120, and positive fast. If those 2 signs out of 4 positive, then you can activate massive transfusion if patient is having a significant trauma. And if patient is having a significant shock index, also patient does fulfill the criteria for massive transfusion if it is more than 1. Or else, if patient is having a RABT scores more than 2, that is also same as ABC score, which is penetrating mechanism, shock index more than 1, positive fast, and pelvic fractures. If those are there, massive transfusion protocol should be activated. Usually, massive transfusion protocol should be activated by senior most person in the patient care management. Okay. Okay. So far, we have discussed about the hemorrhage control. How do you do the hemorrhage control? First thing is you need to fill the tank. How do you fill the tank? By time you can infuse crystalloid, and then you need to give blood, either normal or massive transfusion. Massive transfusion protocol, how do you activate? Either ABC score or RAPT score. And there are chemicals you need to give, which are either tranexamic acid. Make sure you give tranexamic acid within 3 hours of injury, or no more than 3 hours, because after 3 hours over, it has a significant side effect. Therefore, not to give tranexamic acid after 3 hours. Make sure it. Okay. And then you can give reversal agent, which are PCC, or you can give vitamin K. Okay, these are the things you to give, so you to control patient's hemorrhage in addition to physical control. Okay, these are for your references. I will keep it this because I'm not going to talk about detail how you're going to give the component, but usually if you request the massive transfusion, it come in the boxes and then you can transfuse. But if you have a facility to do a thromboelastogram or thromboelastometry, that is ideal to you to assess what component of blood you need to infuse more or less. Okay. One word about the hemoglobin level. I usually hear some people are talking about the hemoglobin. Suppose I am the patient who is coming with trauma. I'm coming with the trauma today. Yesterday, by some instance, I had done my full blood count, and it does show hemoglobin of 13. Today, after I had a trauma, significant trauma, somebody has done a BBG, and it does show hemoglobin of 13. Okay, yesterday one is also 13, today one also 13. But definitely high blood levels. What is the inference? What is the impact of doing a hemoglobin in acute trauma patient? This is useless. Please make sure you don't guide with the hemoglobin level when you're doing the transfusion. But definitely you need to have hemoglobin if I'm going to go for a theater. Okay. If I say you have a bucket which has a 5 liter of fluid and you're going to add some color. Suppose you're going to add some coloring agent, which is 60 gram, okay, 5 liter bucket. You're going to input, you're going to dissolve some chemical, which is 60 gram. What is the concentration of that? 60 gram in 5 liter, that is 12 grams per liter. And you're going to take 2 liters out of that 5 liter bucket. Okay, you're going to take 2 liters, but definitely you know that the other component, that is solvent, also coming with that fluid. Okay, that means you're going to take 2 liters out of that, and you have 24 grams of that solvent. What is the concentration of that? Also 12 grams. And you have remaining in that bucket is 3 liters, which has a 36 gram of solvent, and it also have a concentration of 12. You get my point, I hope. Therefore, your hemoglobin concentration does not change acutely. It samely happens in our body because body can't do such a marvelous adaptation so quickly. Therefore, it is useless I use to check hemoglobin in a trauma patient to guide your blood transfusion. Please make sure not to guide that one. But if you're clinically thinking this patient need to have a blood, definitely you need to infuse blood. Okay? And you not to guide with unnecessary hemoglobin. But definitely, as I mentioned before, if patient is going to go for a theater, he might need hemoglobin level. Okay. Fine. And there is a word called damage control resuscitation. This is usually practiced in whole world. There are 3 main components in that damage control resuscitation, which is permissive hypotension, hemostatic resuscitation, and damage control surgery. Why we are doing this damage control resuscitation is to prevent or minimize lethal triad of trauma, which are acidosis, hypothermia, and coagulopathy. Before I forget one thing, I need to mention, when you are given fluid, please make sure you need to infuse this fluid through a fluid warmer. Definitely you need to give it, because this temperature, I will talk about in the E, temperature is so important, and it is also have a significant role, which is also comes in the lethal triad of trauma. This damage control resuscitation also, the base physiology is that to prevent or minimize this lethal triad of trauma. What are those 3 components? I will mention again. These are permissive hypotension. Permissive hypotension. Why you want to have a permissive hypotension? Okay. Suppose I am coming with significant liver laceration, and my blood pressure is, suppose it is 60. Systolic blood pressure is 60. And you're going to give some fluid and blood, and you're thinking that no, you want to have a significant, you want to maintain significant blood pressure, I want to have a target of 100. By giving that significant volume, the already formed unstable clot might dislodge because of your higher pressure. That is the main aim of doing this permissive hypertension, is to avoid disruption of this unstable clot by higher pressure. Okay. Therefore, patient who is coming with significant trauma, if it is penetrating, your target blood pressure should be 80. But if it is a blunt trauma, your target blood pressure, systolic blood pressure, this is systolic blood pressure, is 90. You can maintain in between like 80 to 90 for a patient who is coming with trauma, but not more than 100. You don't want that blood pressure, because patient who is coming with that, and you're going to maintain permissive hypertension, but make sure that you need to maintain it, not to lower it or not to make it high or low, like significant fluctuation. But you need to maintain that permissive hypotension. Then hemostatic resuscitation. Hemostatic resuscitation by mean it does imply that you're going to give blood. Always make sure you're going to infuse blood it should be in ideally patient's body temperature. For that, you need to give it through the fluid warmer. And the third thing is damage control resuscitation. The main aim is to control hemorrhage, and the control contains spillage, contaminated spillage from upper GI tract and the urinary tract, and then close it and come out. Usually the damage control resuscitation aim is to maintain that surgery within 60 to 90 minutes and close it and come back. And then later you can do definitive management. These all are to manage this damage control resuscitation, mainly targeted to patient to have a significant or to prevent or to minimize lethal triad of trauma. Okay. Then we go into the disability. We have already talked about the airway and the cervical spine protection and the breathing, how you're going to apply oxygen, and what are the things you're going to see. And the C, how do you control bleeding physically, and then how do you do it with chemically, and how do you infuse blood. And then you have a thing called D, or disability. What are the components in disability you're going to assess? Patient's conscious level and patient's gross motor, whether the patient is moving all four limbs or whether there is a significant neurology. You're not going to assess power tone reflexes and things, but you're going to grossly assess whether the patient is having any significant focal neurology. And then you check patient's pupil for size and reactivity, and make sure you check patient's sugar level assay. Okay. And you know how to do a GCS assessment. There are definitely need to know about how to assess the GCS in a patient who is coming with blunted response or significant trauma. Okay. And then the sugar level. I need to mention that sugar level because people who is coming with trauma. See, recently I met a patient who is waiting for neurosurgical intervention, comes with significant level of significant lowering of GCS. And my thought was patient is having a significant brain corneal and thing. But when he checks his sugar level, it was very low. And after he's given correcting the sugar, he was waiting to walk. Okay? Therefore, please make sure the simple things and managing the patients in a simple like RBS, checking RBS is so important. No need to go for high-fi things. Suppose patient who is having a low sugar, hypoglycemia. That is hypoglycemia, usually you mention if patient is having a sugar level less than 4 millimoles or less than 70 milligrams per deciliter. The patient is having a hypoglycemia. You need to see whether the patient is can swallow or not. Whether the patient is having an appropriate conscious level to patient to have a patient can swallow or not. If patient can swallow, you can give whatever things patient can. But usually people give oral glucose. But if patient is comatose or patient can't swallow or there's a high risk of aspiration, then you need to give intravenous glucose. How much of intravenous glucose you need to give? Make sure 10% 100 ml or 200 ml. Maximum is 200 ml. You can give alicate of 50, 50, 50, 50, all four. Okay. Or if going more than that, you can give infusion of 10% dextrose as a 60 or 70 ml per hour. Okay, but make sure that patient is having the other comorbidities you need to think. Okay, when you're giving a significant volume, you need to think about whether the patient is having a cerebral bleeding, whether the patient is having a heart failure. Not these are hard and fast, but as I mentioned, you can give a 50 ml of 10% dextrose bolus and then see if it is not improving another 50, and you can go up to 200 ml of 10% dextrose. Okay, then we go into a thing called exposure and environmental control. Why it is so important to expose patient is to identify any missed injuries. For example, in exposure, what you mainly doing is you expose patient more, so and then you identify whether there are any significant things which cause death, imminent death we have missed. And then you need to turn patient through log roll, and then you identify whether the patient is having any significant injury or bad. Therefore, you need to see whether the patient is having a significant injury by exposing patient, as well as make sure not to make the patient cold, because hypothermia is a killer, and which is one of the three component lethal triad. Therefore, please make sure you expose, but to cover as soon as possible. You need to maintain patient's temperature the normal as normal. You can use the warm blanket or bear huggers, whichever available in your emergency department, to maintain patient's temperature normal. And please make sure to check the temperature in trauma patient. For example, if I ask somebody, can you check the temperature in trauma patient? And they might see my face and stare whether this is important. Yes, it is so important, because it's one of the lethal triad of trauma, and to check whether the patient is hypothermic. If so, definitely you need to control it. And as I mentioned before, make sure when you are giving intravenous fluid or blood, go through it through a fluid warmer and give adequate amount of fluid through normal temperature, not the low temperature. Okay. By summarizing in the exposure, what you want to do is you need to expose patient in all, and then you need to identify whether the patient is in any life-threatening injuries in front and back, and log rolling, and make sure not to drop any degree of temperature. Okay, because when you're going to drop a temperature by 1 Celsius, patient mortality increased by 10%. Okay, make sure all the time when you're managing a patient who is having a significant trauma, check temperature and maintain patient's temperature in normal. Okay. You heard about the rapid sequence induction. You might think that why I'm talking about the rapid sequence induction all of a sudden. As I mentioned before, you need to control the patient's oxygenation. You need to take control of the patient's airway. If patient can't control his airway by its own, or if we are worrying about the patient is whether the patient is going to unstable, we are going to go for some investigation like CTs, and patient might be unstable. Therefore, we need to protect his airway. But always, please make sure that you need to resuscitate the patient before you going to insert a tube. Because once you going to give this induction agent and the paralytic agent, your blood pressure crash significantly. Therefore, first thing is you have to control your bleeding, you have to control your blood, the other unstable signs, and then you have to maintain the blood pressure in appropriate level, and then you can insert the tube. Okay, always make sure that. You're not going to insert tube and then you're going to do a ABCD assessment. It should be comes late. This RSI comes late, not as a first instance. Okay, if patient is having imminent airway, definitely yes, you need to have airway protection, but not the insertion of tube, but you can insert some other airway like supraglottic airways. Okay. There are two entities I'm going to talk about rapid sequence induction. One is trauma, other one is traumatic brain injury. Traumatic rapid sequence induction. There are two main things you need to consider is induction agent and the parameter. When you're going to give an induction agent, it should be half dose of protein. Okay, half dose you're going to in the paralytic agent, but it is same dose you're going to give. In here, you can see that patient who is hemodynamically stable and normotensive and well-perfused trauma patient, there are two options you to go ahead with. I prefer option 2, which is 2 micrograms per kg fentanyl plus ketamine, 2 milligrams per kg, and either Saxa or Rocuronium. Patient who is hypotensive or poorly perfusing or risk of hypotension, what you prefer is 1 micrograms per kg fentanyl and plus 1 milligram of kilogram ketamine, that is half dose of usual, and routine dose of procuronium or the Saxa. Okay, this is our usual trauma RSI. But patient who is having a traumatic brain injury, also you can use as an induction agent ketamine, 1 milligram per kg, and suxamethonium as a paralytic agent. And to blunt respiratory response or the laryngeal response, you can give infused fentanyl. Okay, you can refer this slide later, but make sure when you're doing the trauma resuscitation and if you're anticipating the patient's hypotension or already hypotensive, you need to give half dose of induction agent, but normal or usual routine dose of paralytic agent. When somebody asks about monitoring, what are the things you're going to monitor in a patient who is coming with trauma? In A, what are you going to monitor? A and B usually accompanied, amalgamated, and usually doing, you need to monitor patient respiratory rate and respiratory distresses and the saturation level. In C, what I'm going to do, what I'm going to measure is pulse rate and blood pressure and the capillary refilling. D, what are the monitoring? You monitor patient GCS and the pupils. And E, in addition to monitoring of GCS and pupil, you need to monitor patient sugar appropriately. And E, what are the things you're going to monitor is temperature. Okay, therefore make sure patient is on ECG monitor, non-invasive blood pressure, oxygen saturation probe, and have to have a temperature and the sugar level. This is the ultimate aim of doing my primary survey is to fill this slide. Whether the patient is having a airway threat or not, whether the patient is having a cervical spine immobilized, if it is not needed, whether the patient is on collar, blocks, and the spinal bone. Breathing, whether the patient is having a respiratory distress, what is the patient respiratory rate and saturation, and how much oxygen you are giving. Circulation, what is the pulse rate, blood pressure, capillary refilling, and what are the methods you have already done to control hemorrhage, either chemical, pharmacological, or physical. And the disability, whether the patient is having any disability, like whether the patient is having a gross neurological injuries, whether the patient is having any pupillary deficit or other extent Okay, these are the things you need to complete once you have done primary survey. After that, you can go to the secondary survey. Secondary survey is amalgamated with ample history. What are the things you're going to assess? You're going to ask in ample history. A is allergy, M is medication, P is past medical history, L does have a three component, last meal, last alcohol, and LRMP for female in reproductive age group. E is the event related to this injury. And other things also need to ask about are whether the patient is pregnant or not, whether the patient is having a tetanus status, and recently we have included the COVID vaccination status as well. Secondary survey, how do you do secondary survey? It is not hard and fast as in the primary survey like ABCD. But in the secondary survey, what you usually do is the head-to-toe assessment. You identify head-to-toe assessment, you identify whether the patient is having any injuries. Sometimes you might identify life-threatening injuries while you're doing the secondary survey. If you identify any life-threatening injuries while you're doing the secondary survey, definitely you need to go back to A, B, C, D assessment as or you need to start from the A, B, C, D, and E. Then you need to complete that. Okay, this is how you're going to do. To summarize, what patient who is coming with significant trauma, you need to do primary survey. In primary survey, make sure you're going to assess ATLS, you're going to do a ATLS approach in A, airway, and cervical spinal protection. Make sure all the protection you're going to give to make the cervical spine in line. Okay, I have mentioned what are the things you need to keep the in line and what are the method you can apply to make the patient's cervical spine stabilized. Secondly, breathe in. What are the things you're going to assess? What are the respiratory signs of respiratory distresses and low oxygenation status? Okay, you need to identify and you need to treat then and there that 5 things which comes in the respirator. In addition, you need to give oxygen, adequate amount of oxygen. Please make sure oxygen is a drug and you need to give it in the appropriate dose, not the high dose or not the low dose. And it should be in the appropriate interface. And your target should be 94 to 98. In C, but you have identified whether the patient is having any hemorrhagic shock, and if so, by time you give crystalloid, either 0.9 saline or Hartmann, and then you need to activate massive transfusion protocol or normal, given the blood, and then you can add the chemicals like tranexamic acid. Make sure you're going to give tranexamic acid. It should be 3 hours from the injury, not to the hospital admission. 3 hours of injury, if you're going more than 3 hours of injury, no point of giving a tranexamic acid. It is detrimental sometimes because it has a significant coagulation effect. Therefore, you're going to give. In addition to giving a tranexamic acid, you need to reverse some the coagulation medicine like warfarin, heparin. If these are there, then you need to reverse it. In D, what you're going to assess is to assess whether the patient is having any problem in the disability by assessing the patient's GCS level, pupils, and you need to check the patient sugar level. If patient who is having a low sugar level, you need to see whether the patient is comatose or whether the patient can aspirate, or whether the patient can take orally without aspiration, without risk of aspiration. If so, you can give oral. If it is no, then you need to give intravenous 10% dextrose. As I mentioned, total volume of 200, give aliquot of 50 450s. And then E, you need to see front and back, expose it and see, but make sure patient should be in the normothermic environment. And if not, patient should have to have a blanket, wear huggers, whatever measures you have to make the patient normothermic. When you're giving fluids, please make sure it to be given through the fluid form. Okay, these are the main things we have done in the primary survey. And then you take brief history, focus history, which is ample, allergy, medication, past medical history, last meal, last alcohol, LRMP, and event. These are the main things you're going to assess in a patient who is in a trauma in a history. And then you do the secondary survey meantime. Secondary survey, what you usually doing is primary head-to-toe assessment. In there, once you identify any injuries, you need to manage. But if you identify any life-threatening injuries, you need to go back to a primary survey and do the management. Okay. This is my main aim of doing this lecture, is to emphasize primary survey. Okay. Always make sure you do appropriate care, appropriate management, basically to do the primary survey and resuscitation then and there. Okay. Thank you very much. And if you have any question, I can answer.
Thank you very much, sir, for this very informative lecture. I think everybody would have found it very comprehensive, informative, and insightful. Now let's move on to the question. There is a question about determining the size of the Philadelphia collar.
Okay. Unfortunately, I don't have Philadelphia collar at the moment with me, but you know that there are, when you take the Philadelphia collar, there are on the both sides, on the sides of the collar, you have a yellow button. Then you can up and down press it and you can adjust it. And how do you take the measurement is usually you need to take the angle of neck to the angle of neck to the angle of mandible. Okay. Once you take that measurement, you keep over the Philadelphia collar, and then you keep that measurement on the collar and fix it, and then apply to the patient. Okay. But if I have a collar, then I can definitely show you how to do it. But unfortunately, this is not a practical. I can't show it in a proper way. Sorry for that.
There's another question regarding the oxygen target in COPD patients.
That's good question. I like to hear that kind of a question. Extremely good. Thank you for asking that question. When you have a patient who is coming with COPD, it is our usual, what we usually listen to here is saturation. You can maintain saturation 88 to 92. That is completely misnomer. Please make sure it is a misnomer. There's nothing called COPD patient to have a saturation of 88 to 92. Patient who is coming with critical injury, or suppose patient who is critical injury, who is having a sepsis, or patient who is having a significant injury, patient to have a saturation of 88 to 92 is a misnomer. Patient should have a saturation of 94 to 90. Okay, I'm repeating. Patient who is coming with, whether it is a COPD or not, ideal saturation should be targeted on 94 to 90. But only one instance. If you happen to do arterial blood gas and if showing acute carbon dioxide retention, not chronic, okay? Please make sure. Acute carbon dioxide retention, and patient is showing signs of respiratory exhaustion because of oxygen, where you going, where you giving, in that instance, definitely yes, you need to titrate the oxygen lower and make sure that patient is maintaining the saturation around 80 to 90. But definitely for a critical inpatient, our main target is the saturation of 94 to 90. But if patient is showing a respiratory inefficiency or acute carbon dioxide retention, there's a place for you to come down your oxygen and to maintain saturation 80 to, but for a patient who is definitely coming with critical illness, either trauma patient or a patient who is medically critically ill, saturation should be target 94 to 90, not less than that. Okay.
Thank you, sir. Then one last question regarding hypoglycemia correction.
Yes.
Do we want to give glycogen followed by 25% dextrose or 50% glucose instead of 10% glucose bonuses?
No, there's nothing called 50% glucose through IV. Okay, please make sure you to practice 50% glucose oral. Yes, definitely I can allow, but not more than 20% of dextrose concentration through intravenous cannula. Okay, if you're going to give the dextrose through intravenous cannula, it should be either 10% or maximum 20%. Why I'm saying this, there's a thing called rebound hypoglycemia. Once you give high dose of glucose, the patient's having an adrenergic response and it activates, and the patient hypoglycemic basically because of our glucose low. Okay, therefore, not because of that irritant and things that also have place, but main problem is rebound hypoglycemia. The glucose which you have given and causing hypoglycemia later. Therefore, because of that rebound hypoglycemia, please give dextrose on 10 or maximum 20% through intravenous cannula. Definitely not more than that. Definitely not 50%. You can give 50% or 1000% through orally, but not through intravenous. Okay.
Thank you, sir. I think that's all for the questions so far.
Thank you.
I would like to thank Dr. Bandara Ekanayake, consultant in emergency medicine in National Hospital of Sri Lanka, for his excellent lecture and the precious time he has spent in this Sunday. Thank you, sir. The lecture was very informative and very comprehensive, and you have covered a vast area in trauma management in this short period of time. So this is the end of today's webinar. So you will find the link in the chat box. So kindly give your feedback and as well as the post-assessment questions. To receive your e-certificate for the participation, again, you have to fill the assessment questions. So I hope you have updated your knowledge on trauma management. And so this is the end of today's webinar. I hope you have a wonderful Sunday and enjoy the remaining part of the Sunday in a pleasant and a productive manner. Goodbye.